Conversations in Frailty, the podcast for Derbyshire clinicians.
Great to have you listening again, or perhaps for the first time if you've just joined me. You might be a doctor, ACP, ECP, or indeed another health professional from our growing teams, and perhaps you're in training or newly qualified, or like some of us getting a bit longer in the tooth. But wherever you are on your journey, I think there'll be something here for you as I discuss hypo and hyperglycaemia in our frail patients with diabetes with specialist nurse Beth Cooper.
Hi, I'm Beth Cooper, diabetes specialist nurse in North Derbyshire.
Great to be chatting again. And so today I think we said that we'd have a bit of a chat about some of the more acutely unwell diabetic patients who are frail. So I think we'll start off with thinking about hypoglycemia.
Yeah, I guess acutely unwell, but also maybe things that people need to think about routinely to avoid the acutely unwell part.
Indeed,
is what I would be thinking.
Preventing them getting unwell.
And just going back to the whole definition of frailty and the way that we think about patients, something which I often challenge myself with is age being just a number. So remembering that when we are reviewing somebody, make sure you're looking at that you're thinking about the person in front of you, and because somebody can be much younger in their 50s or 60s and have all the markers of frailty and need these adjustments making or not. So hypoglycemia, what is it? I guess is what the first challenge, because sometimes that causes some confusion. And when I'm doing a review with a patient, I will always ask what they consider to be a hypo. I've never forgotten going to see an elderly lady at home who had type 1 diabetes, and she assumed that a hypo was when she was unconscious on the floor and needed an ambulance. That was her assumption of what hypo was, because the rest of the time she was awake, she could treat it, she didn't consider it to be a problem. So we still work on the basis that 4 millimoles is a hypo. Anything below 4 is a hypo. And that's, 4's the floor is the definition that Diabetes UK have been using for years. So we've stuck with that.
And that's the same across the board, frailty or not?
There is some variations in children's management in that they're actually managing it slightly differently now, but I won't spend time on that. But in terms of the adult population and certainly frailty, anything below 4 needs treating as a hypo. And so what is a hypo, I guess? So for everybody, their symptoms might be different, and often the symptoms of hypos change as people get older. Obviously, if there's people with cognitive impairment, they may not even understand or be able to communicate that they're having a hypo. So the first stages of hypos, when it's going into the 3.5 to 3.9, we might be thinking about behaviour changes, visual changes, seizures. Then, as it starts to drop below 3, sorry, I've said seizures there, but that's going to be happening when it's below 3.
Okay.
So I guess for someone that can't tell you about symptoms, it's about looking for changes in their behaviour and could that be a hypo?
It's something we ought to think about when we often on a care home visit, for example, get called to someone who's just not themselves or a bit confused, and our brain goes into delirium. I often say to people when they're thinking through the pinch me acronym we use for delirium that one of those H's, think of hypo.
Yeah, brilliant. And I think sometimes when people are perhaps suddenly not eating very much and treated with a medication like gliclazide, hypoglycemia can become a bit chronic if they're not having their blood glucose tested regularly. And that could be potentially missed if they're not being monitored for it. As they are, if that hypoglycemia is not treated in that moment when they're starting to drop below 3, their symptoms become more severe and they can start to lose consciousness. So it's about careful management in this group and making sure that we treat things early. So how do we treat it, I guess, is the next question. So historically, everyone's talked about Lucozade. Since the sugar tax, most drinks have half the sugar content that they did. The tricky thing is that most of them taste just as sweet because they've got sweeteners in. So it's caught out quite a few patients in that they haven't looked at the label and they're drinking it thinking it's going to treat. Whereas before you would need 100, 150 mils of Lucozade, you now need 330 mils. So you need a whole small bottle of it.
Okay.
So I actually steer away from fizzy drinks because it's too confusing. Dextrose tablets that you can get from the chemist. Are a great treatment, and it would be 4 or 5 dextrose tablets. Jelly babies are great.
Yeah, we often
4 to 6 jelly babies. Again, depends on the individual whether they're able to be disciplined and not eat too many. And some patients who will eat the whole bag if they have the opportunity. So finding a treatment that's appropriate isn't going to be eaten excessively. We steer away and we try and avoid prescribing glucogel and those kind of things. So glucogel is, I think, about £7.50 for 3 tubes, and a bag of jelly babies is about £1. So most people can usually buy their own over-the-counter treatment. So I would really encourage that. And also, it's reinforcing trying to help people manage their own hypoglycemia, not the doctor prescribing something to manage their
medicalising it less, in a sense that they're empowered to do it themselves. And
then a reminder that after they've had that fast glucose, they need to follow it up with a snack, a sandwich, a piece of toast, something slower carbohydrate. So whatever's caused the hypo's likely to carry on working, so they need to have some longer acting treatment. And then just a review of what do we think's caused that hypo, does their medication need adjusting? Something I just want to quickly touch on is glucagon injections. They are a medication that isn't prescribed very often. They come in a little orange box, usually prescribed for type 1 diabetes, but the purpose of them is they work as an intramuscular injection that's given when someone's unconscious with a hypo. So first of all, we don't really want to be prescribing someone that, because we want to avoid them ending up in that situation. But as a service now, we've encountered 2 or 3 patients where they've been requesting glycogen injections from the GP practice repetitively, and it hasn't been picked up on the prescriptions. So I had one elderly man who was giving his wife it 2 or 3 times a week. And it wasn't
a big red flag.
Yeah, he was really happy because he felt like he could help manage her diabetes, because when she went low he gave her this and she came round and he gave her some snack. But she was going down to 1.5, 2 frequently. So for her it was a case of adjusting the medication. Similarly, we've had a young person in High Peak where they had a family member administering this to them frequently. So what I would say is that it's there as a good emergency for if somebody is vulnerable and it's felt that it's needed just in case, but actually just make sure that no one's is requesting it routinely, because it's not a routine treatment. They obviously need a review of their medication.
It's a big flag for us to say, actually get this patient reviewed or look at what they're on.
Absolutely.
And so otherwise the management of hypos is essentially pretty similar between type 1 and type 2 in the kind of acute situation.
Yes, it's exactly the same. And obviously something I didn't mention actually just very quickly is, when you've done that initial treatment, what happens if it doesn't work? So how quickly do you follow it up? So usually we would recommend that you recheck the blood glucose after 15 minutes. And if that initial treatment of fast glucose hasn't worked, you would repeat that. And then people will say to me sometimes, so what if it doesn't work again? And that does occasionally happen. I would actually say that if you've got someone elderly and you feel like they're in a severe hypo that isn't responding by the second treatment, that's probably the time to call the ambulance. We used to say 3 treatments and then start to think about calling 999 if they're not coming round or their blood glucose is not starting to come back up. But we all know that it takes quite a long time to get an ambulance now. So the paramedics are not going to complain if they get there and you've treated it and the patient's fine. So it's just really thinking about that
awareness. Fine. And anything else on hypos, or do we feel like I think we've probably covered that?
There's probably more, but I can't
So let's go to the flip side, and I think this is a side that often a lot of us feel not highly skilled around the concepts of the different types of hyperglycemia and when we should be worried. Just talk us through, again, how it differs between type 1 and type 2.
Sure, okay, well, you've just said my first thing, in which that, again, just revisit, does this patient have type 1 or type 2 diabetes when their blood glucose levels are raised? Because it's going to massively influence what you're going to do next.
Yeah.
So, thinking about what is hyperglycemia, if you look at guidelines and certainly hospital protocols, often a blood glucose level above 13, 14 is considered to be a high blood glucose level. So you will often find that there are protocols in the hospital where if someone's blood glucose is over 14 or 15, they should have rapid insulin. What we've found in the community is that protocol has sometimes come with clinicians that have moved from secondary care because they've had it as a safety net. That protocol is in place because in the hospital they've had situations where someone with type 1 diabetes wasn't managed when they had hyperglycemia. So the way that they've coped with that is they've put a blanket policy in place that if anyone is hyperglycemic, we're going to give them NovaRapid to bring it down.
Yeah.
However, in the community, that is only really appropriate treatment for someone with type 1 diabetes, particularly in frailty. So we'll go for type 1 diabetes first.
Yeah.
Again, people will generally have their own individual ranges, but for type 1 diabetes, if someone's blood glucose is above 15, that is hyperglycemia. Okay. And what I would say is they should have an individual care plan in place for what should be done in that situation. Either if they're managed by the community nurses or in a home, someone should have supported that patient to have what we call correction doses of rapid insulin to manage that hyperglycemia.
So they need a plan with guidance around how many units, depending on the numbers, I'm guessing.
Yeah, exactly. So they would have an increase in their dose of insulin. They would also need to have, they would have to have equipment available to test for ketones, so that, and everybody with type 1 diabetes should have a ketone meter. Yeah. So that if their blood glucose is high, someone can support them to test that.
This is a blood ketone meter.
Blood ketone meter, exactly. Yeah. And they can be supported once they've got ketones. They can often be cleared in the community. It's not always an emergency. Just to clarify that, if they're having extra insulin and the ketones are not clearing, or their ketones get to a significant level, so 2 to 3, then we would be looking at admission. But again, if you are caring for somebody that has type 1 diabetes, get support with writing an individual plan so that something's in place to understand how that would be managed. Yeah. Something that's often quite confusing with type 1 diabetes and illness is if they have ketones, not only do they need an increase in their insulin, they also need glucose to help with the energy to clear those ketones. It feels very counterintuitive because they have high blood glucose. Why would you give them glucose? But that is what's needed. And the simplest way I explain that is your body needs energy for everything that it performs. And if you're going to give rapid, they need easy accessible glucose with that rapid insulin to enable them to clear the ketones.
Okay.
So a lot of the Trend website's excellent for this. It has guidance on how to do that, but it's often where things escalate is if someone is not able to have some glucose. And I think if somebody with type 1 diabetes is unwell, they have ketones and they're not able to eat and drink, that's a hospitalisation situation because it's very difficult to manage that. They would need to start having to have IVs.
But otherwise, essentially, you're saying the glucose they're having is eating and drinking on top of the top-up rapid insulin that we're giving.
Exactly, yeah. And the reason I said about fast glucose, quite often they don't feel very well, then they're poorly and they don't really want to eat a meal, especially in the frail community. They don't touch what meal they've been given, and so in that situation we would recommend food replacements like orange juice or glucose drinks, that kind of thing, to help give them some energy, and staying very well hydrated to help clear the ketones. Right, let's look a bit more at type 2. So going back to the target ranges that we talked back on the previous podcast, that will hopefully help people to feel more relaxed about where are we going to be bothered about when someone's hypoglycemic. So the target range of maybe 6 to 12 gives you an idea of where we want you to be most of the time. But we do have some people who would trend into the 20s when they've had sweet treats. And I think that's where it comes back to just fully understanding this individual. It's not always easy when you're doing an acute visit and it's all got to happen quite quickly. But are they unwell in themselves? Is there any reason to feel concerned apart from this blood glucose level here?
Which might be a very chronic picture of...
Yeah, and if they are undertreated for their diabetes and they've had a high blood glucose in the 20s for weeks, it may be that actually we need to look at changing their medication.
Yeah.
But it's not an acute situation where they need rapid insulin to treat it.
Yeah.
It's more a case of that their diabetes needs better management. And if it's a one-off blood glucose of say 25, 26, that patient isn't clinically unwell, then we aren't going to be that bothered about it.
No.
We're just going to keep an eye on them and check that comes back down again. I guess something that I'm thinking about talking about is just what are the causes of these hypers?
Apart from the patients we've mentioned who won't stop eating the sweet treats.
Yes, yeah. What is causing these? And I guess it's just revisiting a bit like with hypoglycemia. What has caused the hyperglycemia in the first place? Do they have an underlying infection? And because quite often there's a service we notice that when patients have an underlying infection, that's treated, but the diabetes isn't always thought about.
No.
And on the flip side, sometimes the diabetes is clung onto, but the underlying infection isn't always treated. So it's just a reminder really of that holistic thinking and something's triggering this. So much so that I remember one lady with type 1 diabetes who said that her blood glucose went up 2 or 3 days before she became unwell with the flu or something like that, because it was showing her body was not very well.
Sort of fighting something.
So other things to think about: are they taking their medication regularly? Is that a factor in why they're becoming hyperglycemic? Do they need support with their self-management? One more thing to think about on the high blood glucose level front is HONC or HHS.
Is that essentially the same condition?
Yes.
Just giving it different
names?
names?
HONC is really the old name that we used to call it.
I think nice is now HHS, isn't it?
Yeah, and it's not very common, but sadly the risk of death is 15 to 20% when somebody has that. So it's just really to think about what things would we be looking at that are different. So the person would have type 2 diabetes. They're usually treated with diet or oral anti-hyperglycemic agents. They tend to be elderly or frail patients, so it's this group of patients that we're thinking of. The symptoms tend to be a slower onset. The difficulty is it's confusion, it's dehydration, it's things that correlate with other things that you might be looking at, like delirium. They usually have a very high blood glucose level, so it's often off a scale recordable. So when you're testing with a finger prick blood glucose level, that usually only goes to about 32 millimoles. But we've known patients once they're admitted that it's coming out as 50.
So it will just record as high.
It will record as high on the machine. I think if you're getting that bundle of symptoms, often they're not eating and drinking properly. They're getting dehydrated, and I think it's a case of if they've got extreme blood glucose levels and they're not managing to drink, that's a clear signal that they need an admission. If,
to be devil's advocate, they were a patient who was very frail and had clear wishes on their respect form that they wanted to avoid hospital admission, what would be the best way to sort of symptomatically manage an HHS? Is that a safe thing that we can do for them?
I think that's a really tricky question, because the safest No, it's absolutely fine to ask it, but it does happen. These things do happen, and I guess it's a consideration in those patients. what they need is IV insulin and glucose infusion. That's what's going to bring it down, and it is quite likely that they are going to die if we manage this particular situation in the community. Now, if they are very close to end of life, or they've made it very clear that they don't want active treatment, it may be that the most appropriate thing is that they are allowed to die of this.
I guess perhaps a learning point then is to say, actually, in a type 2 diabetic, when you're doing a respect form, maybe that should be an area that you should think about covering. If they say they don't want admission, sometimes we have, except in the case of X, and it might be a useful thing to put down.
I think that's a really sensible thing to pick up, because I think it is potentially something that is a bit quicker to treat. I guess having a conversation like this, we're oversimplifying it massively, and it's possible that this person with HHS has loads of other comorbidities that are complicating the whole situation, and that may make the decision easier in that point of time.
But it's one to think about, isn't it? I guess
Absolutely.
For us, just these things are always better thought about beforehand, and then you can manage them better.
Well, you've given me some food for thought, and I'm going to go away and think about it a little bit more, actually, because it's the kind of question that we might be asked. But I think you're right that historically they would have been rushed in an ambulance and treated, but we are trying much harder, aren't we, to make sure that they do get their wishes in terms of advanced care planning. So
I don't like the phrase on respect forms, treat reversible causes, because I think it's rather vague, but actually in this circumstance you could certainly say this is a potentially reversible cause.
Potentially. So, like I said, it's hard because we don't know how long has the onset been, what is the reason that they're not eating and drinking, is there some underlying symptom that actually has led to this that isn't going to be resolvable.
No.
I don't know the answer to that question.
Okay, well, I've given you a tricky one there. Fine, just to finish before we go then, we wanted to touch on reminding people about 6-day rules, I think, because those have progressed, haven't they?
Yeah, and I think I'll try and summarise this as quickly as I can. I've talked about it a tiny bit. Let's try and... So, 6-day rules for somebody with type 1 diabetes. Never omit their insulin. In fact, usually they need more insulin during illness. Thinking about ketone reduction, replacing and maintaining fluids, so making sure that they're drinking fluids at least 100 mils an hour, so having fluids going in continually, and testing their blood glucose and their ketones regularly, so 2 to 4 hourly, to make sure that that isn't neglected. With type 2 diabetes, we have the mnemonic of SADMAN. So there are some drugs that clinicians will already be stopping when somebody's unwell, but there's a few key ones that we think about with diabetes. So SGLT2s, we did go through a phase of trying to say to stop that if someone's at risk of dehydration, but it wasn't being stopped enough. So we now say if someone's unwell, stop that medication straight away because of the risks associated with it. Metformin needs to be stopped in acute unwellness because it can cause acidosis. So those are the two main ones, alongside other medications that are in the SADMANs. So
those are the S and the M, aren't they?
We've got ACE inhibitors, diuretics, ARBs, and non-steroidals as well. So hopefully, if we adhere to that, then that's going to limit the complications that come from those
drugs. And then I think, like you touched on before, when the patient has recovered, particularly if they've been admitted and these things have been left off, thinking about actually, do we need to reinstate them potentially?
Yeah, exactly, because we see, and in that frailty journey, it's often a roller coaster, and you don't always know where they are in their life prognosis. So I think it's just a case of, right, well, let's get it reinstated as quickly as we can if feasible.
Fantastic. Well, we've done a bit of a whistle-stop tour of hypos and hypers and sick-day rules. And I would encourage any listeners who didn't manage to listen to Beth's first part of this diabetes duo to have a listen back to that one as well, because there was lots of useful tips in that one too. So thanks ever so much, Beth. It's been fantastic. It's been learning for me, and I'm sure for the listeners as well.
Yeah, well, I hope it's been useful to people. It's been a pleasure.
Great.
So lots of practical information here from Beth.
Symptoms of hypos can change and be unreported as patients become more frail, so we must consider it in patients with diabetes presenting with delirium. Also, beware being caught out by the low sugar fizzy drinks that catch patients out when they're managing hypos. And do see repeat glucagon prescription requests as a big red flag. Glucagon IM is not a routine treatment. Now, those of you who know me will be aware that I'm very much an advocate for improving the quality of our respect conversations. So talking about severe hyperglycemia and potential admissions is definitely an area to consider in these patients. Don't forget that a few reflections on this make great material for your appraisal or portfolio. And do join me next time when I'll have another delve into mental health in frailty with a focus on anxiety and psychosis. As always, remember that this is a discussion with one expert in the field. When making individual decisions about patients, always take local and national guidelines into consideration and use your clinical judgment.
Conversations in Frailty. Thanks for listening.